Assalamu alaikum everyone. So now I'm going to start the lecture. मेरे ख्याल है students भी आ गए हैं सब. I hope you can see my screen. Bismillahirrahmanirrahim. So today's topic of the lecture is diabetic foot. Let's begin. So this is an abstract from the famous Journal of Lancet. The enormity of the global burden of diabetic foot disease, this much neglected, but potentially devastating complication of a disease that is reaching epidemic proportions. Someone, somewhere loses a leg because of diabetes every 30 seconds of every day. Yes? So today's agenda of the lecture would be to cover a bit about the global burden of disease, pathophysiology, risk categories, classification of ulcers, evaluation, management. And I'm not going to talk about Charcot foot because Charcot foot itself is a big topic. So I'll try to cover up these part of the topics today. So coming to the global burden of disease, currently 415 million adults are estimated to have diabetes, and by 2040, this number is estimated to increase to 642 million. And every 20 seconds, an amputation is performed on an individual with diabetes somewhere in the world. More than 5% of diabetic patients have a history of the foot ulceration, and the cumulative lifetime incidence may be as high as 25%. Now, this is all related to an international research. Okay, हमारा local data अभी मैंने नहीं बताया आपको. This is a global picture, and that is also back of 2018, as you can see here with the reference. Incidence and prevalence figures related to both foot ulcerations and lower extremity amputations have substantial global variation. ठीक है ना? Even within our country, there is a variation. You will see in the further slides. The variation may be partially explained by differences in the measurement of amputation and diabetic foot ulcer, as well as the ascertainment of diabetes, demographic factors, setting, or other confounders. So this was captioned back in IDF in 2017 that I took the picture of. Here again, they are saying that there is, with the lifetime incidence of foot ulcer occurring in up to 25%, we need to pay far more attention to the diabetic foot and shift our focus to preventing ulcers rather than treating them as a whole, na? Because morbidity, mortality बढ़ जाती है. And diabetes morbidity rates are staggering high, and the 5-year mortality rate after a low extremity amputation is only second to a lung cancer. So diabetes itself is a chronic disease with chronic complications to deal with, but having a diabetic foot ulcer add to another disease to the diabetes syndrome itself. So this is just a picture to show you the lower extremity amputation, how the mortality increases year-wise after you get a lower extremity amputation. Now, next I'm going to tell you about our local problem. Lahore, this is the study from Lahore. Okay, a frequency of diabetic foot ulcers in patients with diabetes presenting to a specialist center at a tertiary hospital in Lahore has been reported. And according to them, now you can see number of foot ulcers and Charcot foot, a kind of an idea of prevalence in our local population. So total sample population was 1940, and number of foot ulcers was nearly 7% in that population. Out of these foot ulcers, 61% were on the plantar surface, and 74% were neuropathic. So I think you can imagine lower, the plantar surface of the foot, and having loss of sensation adds to the ulcer formation of in the diabetic patients. This is another study from Faisalabad, where they have checked 10,000 more 10 and a half 10.5 thousand medical admissions, and out of them 23.4% were diabetic foot syndrome. And in that population who developed this diabetic foot syndrome means they may have ulcer, they may have Charcot foot, they may have various other problem related to the foot, can be cellulitis and so on. And in them, there was 21.7% of deaths. So, and if you compare it with the cerebrovascular and other complications, it is so close related to the cardiovascular death, right? 26% and 21.7% is very close. So this is also an old study from 2018. Now let's talk about the pathophysiology. This is basically a vascular disease, as well as there is a neuropathy. And the neuropathy can be sensory, can be motor, can be autonomic. 20 times more prevalent in diabetics. Okay, vascular disease, obviously we say that diabetes is equivalent to a atherosclerotic vascular disease, right? So definitely, if person is diabetic, there is a chance of 30 times more prevalence of having a vascular disease as well. Diabetics get atherosclerosis obliterans or lead pipe arteries, calcification of the intima media of the arteries, often increased blood flow with lack of elastic properties of the arterioles. As a result, the pressure and the shear force is increased in the arteries, right? And this leads to complications, that is claudication, associated coronary and cerebrovascular disease, and delayed ulcer healing. Can you identify what is the abnormality on this X-ray? So, yes, G? Yes, ऑस्टियोमाइलाइटिस तो अभी इसमें पिक नहीं हो सकता. इसमें बोन्स की सर्फेसेस आउटलाइंस आर वेरी क्लियर एंड वेरी smooth. So the possibility of osteomyelitis is less likely, but it is very rightly said that there's calcification along the arteries. I hope you all can appreciate. This is like lead pipe arteries, जो मैंने अभी आपको बताई हैं, the one I just told you. So when the arteries are calcified in their margins, they can be picked up on the X-ray. So when you order an X-ray of a foot or a limb of a diabetic patient to see if there is an osteomyelitis or any other bone involvement, make sure you look at the X-ray very clearly and very keenly to pick other findings as well. Now coming to the neuropathy, changes in the vasa nervosum with resulting ischemia can be the cause of neuropathy again. And there is an increased sorbitol in feeding vessels which block the flow and causes nerve ischemia. And there is an intraneural accumulation of advanced products of glycosylation. Obviously, this is the basic pathophysiology which is happening in diabetes all over. Abnormalities of all three neurologic systems contribute to the ulcer formation. Now we go one by one. Okay, sensory neuropathy, there is loss of protective sensation. This starts distally and migrates proximally in stalking distribution. Large fiber loss results in light touch and proprioception loss, and small fiber loss result in pain and temperature. Usually there is a combination of the two which is present. Okay, so it's not like you will get a single pathological finding. You'll always get a mixture of things. There can be sensory neuropathy of various type, then can be motor neuropathy, there can be ischemia going on. So two mechanisms of ulceration in sensory neuropathy: unacceptable stress, but few times. This result this results from objects like rock in the shoe, glass, burn. Okay. Now, this is an unacceptable stress, means patient cannot bear this stress, and it can happen sometimes, not very often, but this can result in injury. Then there is acceptable or moderate stress, but repeatedly happening, like improper shoe wear, or there is a foot deformity. Okay. So both mechanism can be the reason for ulcer formation. Coming to the mechanism behind motor neuropathy, this usually leads to foot deformities, and from those foot deformities, ulcer formation happen. Now, what are the foot deformities? They are hematose, claw toes, prominent metatarsal heads, hallux valgus, and collapsed plantar arch. I hope you can appreciate these all deformities in the associated pictures here. You can see the top of the figure here. There is a deformity of the toes and the forefoot here. And then there is a pes cavus, which is like a deformity of the metatarsal heads and forming of a high arch foot. Okay. Then there is pes panus here, this one, or you can say flat foot. Okay. This also leads to these pressure areas developing and having, injuries. So the whole, architecture or the formation of the foot is so important in, in expecting how a foot can be prone to ulcer formation or damage. So this is a mechanism where you can see that when there is a hallux valgus formation, then how this leads to prominent metatarsal head here in the part A of the figure. And this prominent metatarsal head can be the source of, continuous pressure and ulcer formation. Similarly, over here, you can see the deformity in part B. Okay, so these are the various foot deformities. When you go into the depth of how diabetic foot really happen, then these factors have to be taken into account. So motor neuropathy mostly affects foot ulceration, forefoot ulceration, okay, fore part of the foot. And there will be intrinsic muscle wasting, which leads to clawing of toes. And there can be equinus deformity contracture. You know what is equinus deformity contracture? Here, the Achilles tendon become contracted. As a result, the hind part of the foot, that is the heel, is mostly off the ground. So the whole pressure comes on to the forefoot. This is how it happens, okay? Coming to the autonomic neuropathy, it regulates sweating and perfusion to the limb, which is important to keep the skin moist and well hydrated and, well perfused. When there is loss of autonomic control, inhibits the thermoregulatory function, and this leads to inhibition of sweating as well. This results in dry, scaly, and stiff skin that is prone to cracking and allows a portal of entry for bacteria. This is how an autonomic neuropathy can affect the foot for ulcer formation. You can see cracky skin, which is dry. Okay, this is black and white in color. So again, there are various pre-ulcer cutaneous pathologies as well, which can lead to ulcer formation. Persistent arrhythmia after shoe removal. Then there can be callus formation, callus with subcutaneous hemorrhage. Then there can be fissure, interdigital maceration due to fungal infection, and there can be nail pathology. So for example, if you see here, there is a callus formation. This results in the breakdown of the skin here. And then there is number 3 is the subcutaneous hemorrhage. And then there is deep foot infection with osteomyelitis ultimately over here. So this is like, one example or one flow of how pathology works. And there can be other methods like just a fungal infection is mentioned here, and nail pathology as well. So you can you appreciate the erythema over here, and how the nails are also not very clean. They are light yellow in color, and you can see this is a foot deformity. Okay, this is the hammer toe actually, hammer toe deformity. Again, this is a large fungal infection of the nail over here. You can see the surrounding skin is quite red, probably because of the pressure or an associated skin infection which is going on here. And this is the plantar surface of the foot where there are many calluses. You can see these calluses can break down and become the source of entry for bacteria. So we have risk categories for these ulcer diabetic foot formation. In the category 1, there is a loss of protective sensation and normal plant, and then this becomes a moderate risk diabetic foot. Okay, category 0, there is a normal plantar sensation, and you can classify that foot as to be low risk. But when there is a loss of protective sensation, now what are the loss of protective sensation? They are the large fiber and small fiber sensations I explained earlier. Once they are lost, then you can label that patient's foot to be at moderate risk. You have to inform the patient that your foot is at moderate risk for ulcer formation or diabetic foot. Okay, here your work starts. If you don't pick this, then you are mistaking, then you're not dealing with the patient correctly. Then category 2, there is not only loss of sensation, but also with either high pressure or poor circulation or structural deformities in the foot, or there can be fungal infections. So all other type of pathology that I've mentioned earlier can happen here. And now this patient is at high risk of diabetic foot ulcer, and then worsening of the disease. Once the patient had an experience of ulcer formation or amputation or a neuropathic fracture, that they mean to say is the Charcot foot deformity, and that patient is supposed to be labeled as having a very high risk of diabetic foot. So the difference between high risk and very high risk is very clear. There is a history of amputation, ulcer, or fracture, which is important, which you have to take and explain that. So let's begin with the patient evaluation method. Obviously, there is a medical history which you have to take properly. You have to assess the patient from the vascular point of view, any history of cardiovascular disease, any history of ischemic stroke, and so on. Any fractures, any foot deformities, and so on. And then identification of the foot at risk. That is the risk categories that I just mentioned. You must label every diabetic patient for the diabetic foot category, which we don't usually do in our clinical practice, but this should be done. So this is really our job, but we always miss it, don't we? We don't examine the feet of our patient. Hum to clinic mein we just write prescription and send them back. We hardly look into their feet, hardly ask them to, put off their shoes and show us your feet. Any fungal infection growing in between the nails, you should check them all. And then you label that patient to have a 0 risk or low or moderate, high or very high risk. Okay. So from medical point of view, you must optimize the blood glucose control, decrease by 50% of the chance of having a foot problem. If the sugar control is good, then there is a 50% less chance that the patient will develop any diabetic foot at all. Moving on to investigation, do these complete blood count, urea creatinine electrolyte, liver function test, hemoglobin A1C, fasting lipid profile, urine DR and microalbumin, fundoscopy, pus and tissue culture if it is there, ultrasound of the arteries, arterial Doppler of the legs, and if required, you can move on to angiography of the lower limbs. This is to assess how severe the disease is and how vastly distributed the micro or macrovascular disease in a diabetic patient is, because you have to address the patient as a whole. Then assessment of the peripheral pulses is of paramount importance, and if any concern, you should actually refer the patient for these type of assessments. That is the ankle brachial index. Now this is a normal range that I have written here, that is 0.9 to 1.3. Consider at age 50 years and every 5 years thereafter. So ankle brachial index तो हमें हर visit पे patient का करना चाहिए who is 50 years and thereafter every 5 years. So a proper multidisciplinary diabetic foot or diabetic team should have these facilities, should have this annual screening program in their center, so that the patient's chronic complications can be prevented. This is the part of the preventive medicine, but we don't, really practice this. We should. Then there is claudication. If there is claudication, absent dorsalis pedis or posterior tibial pulses, you should look for them. Any foot ulcer. Limitations are underestimates severity in calcified and sclerotic vessels. So if a patient's blood vessels are already sclerotic or calcified, then you may not get the correct answer from the ankle brachial index measurement. Okay. Then that time you have to move on to further sophisticated investigations. Check the toe pressure. Normal toe pressure is 40 to 50. Now for the measurement of the toe pressure, again, we need sophisticated instruments in our setup, which is not always present. And they need high frequency probes and specialized instruments. Then there is a measurement of cutaneous pressure of oxygen at the level of toe. This TCPO2 is the toe cutaneous pressure of oxygen. Okay, it should be more than 30. Again, for this we need very special probes and very specialized instruments. I haven't seen in my practice so far. I have only read about them. Then extensive but helpful in amputation, deciding the amputation level. So these are the features or points for vascular assessment of the diabetic foot patient. This is the severity of the peripheral artery disease as interpreted in the ankle brachial index. I have told you the normal value, and these are the mild, moderate, and severe categories according to the levels you can see. You can always find these, categorization elsewhere in the books and on the internet as well. This is how you measure the ankle brachial index in the right and left side. First, you measure in the arm, and then in the foot. Now, I'm not going to go into the detail unless you practically perform it. You have to understand at that time how you measure it and how you apply it. So, moving on to orthopedic evaluation. Look for any ulceration, deformity, and prominences, any contractures. These are very important features. You should learn to pick deformity and prominences and tell the patient that your foot has this problem, because every foot is different. Okay, you have to inform the patient your foot has these prominences, these contractures, the muscle is wasting. What further adaptation that patient has to take accordingly. Then you can perform X-ray to look for lead pipe arteries, any bony destruction like in Charcot or osteomyelitis, any gas present like gangrene formation, any presence of any foreign bodies. Now tell me, what is the problem in this X-ray? Can anyone pick the finding? हाँ बिल्कुल, बल्कि आप देखें, if you see there is an amputation and the proximal phalanx is actually amputated, right? But still the infection is probably not healed very well, and there is still gas formation here on the right side. And on the left side, you have very rightly pointed out that there seems to be deformed phalanges, and these are the deformed toes. Basically, can be because of loss of muscle. Because of muscle wasting and formation of contractures. Claw toes can be there. So this is important. You see how you pick different findings on the X-rays. Then there is the modality of nuclear medicine can be used as well, but it's sometimes overused. Combination of bone scan and indium scan can be helpful in questionable cases, like if you see normal x-rays and still you clinically suspect that there is problem, then you can move on to the nuclear medicine modalities. Best screening way is through indium, and if positive, then bone scan to differentiate between bone and soft tissue infection. Now, this is a very sophisticated area of assessment, which is not very uh, commonly practiced. Sometimes you have to, just refer the patient to the orthopedic surgeons, and then they move on to these type of sophisticated investigations to assess their management level. CT scan can be helpful in visualizing bony anatomy for abscess or extent of disease. And MRI has a role instead of nuclear medicine scans in uncertain cases of osteomyelitis. So we being medical people, we have learned to perform MRI in such cases to assess the uncertainty of osteomyelitis. Now, how do you assess the foot at risk? Now I'm coming to the basic assessment, okay, how you examine. So the Siemens Weinstein monofilament is very important. You should have them in your pocket or in your clinics, really. This is a very easy method to assess the patient's protective sensation. Usually it is a 5.07 is the number, which is equivalent to 10 gram, which seems to be the threshold here. 5.07 is the pressure, okay? 90% of the ulcer patients can't feel it, and it is a very helpful in screening purposes. This is how you perform it. You can see these orange areas are the pressure points where you apply this filament, and you assess the sensation. Now I'll read out how you perform this test. This is important, so I want to read it out for you. How to perform the sensory examination: conduct in a quiet and relaxed setting. Okay, so that patient can sense it very well. Begin by applying monofilament to the hands, elbow, or forehead so that patient know what to expect. Ensure that the patient cannot see whether or where the monofilament is being applied. You may have to ask the patient to close the eyes for the actual assessment. Test the three sides on both feet as shown in the figure. So the figure shows here the three sides, but there are various other uh, methods where there are 5-point assessment, 8-point assessment. So it all depends upon your practice and your daily experience, that how you are picking the abnormalities. So apply the monofilament perpendicular to the skin surface and apply sufficient force to cause the filament to bend or buckle a little. Now repeat the application twice at the same site, but alternate the application with at least one mock application in which no filament is applied. So total 3 questions per site. You ask the patient twice, are you feeling it? Are you feeling it? Are you feeling it? But out of these 3, 2 are actual application of the filament and 1 is no application or maybe application elsewhere. So the patient know, okay, mujhe to lag raha hai, I can feel it. But with mock application, you can trick the patient's assessment that he or she is telling the truth or not. Protective sensation is present at each site if the patient correctly answers 2 out of 3 applications. Incorrect answers, the patient is then considered to lack protective sensation and is at risk of ulceration. Okay. Which category was it? It was a moderate risk category. Then neurological exam. This can be performed through the tuning fork at our healthcare setup easily because the biaesthesiometer is quite expensive. However, it is the best predictor of foot ulcer risk to assess the vibration sense. Okay, so these are the various methods. And this is a flow chart which tells you the mechanism for foot ulcer formation. This is basically the same that I have discussed so far, how the patient develops neuropathy, Okay, over here, neuropathy and then ischemia, and how both of them are contributing to ulcer, some leading to amputation through the process of gangrene or directly. Any background of neuropathy and even trauma can lead to foot deformities of various types like shortcut foot later on, and then that can also lead to amputation. So a little bit of summarize flow chart. Now this is important. This is a University of Texas diabetic wound classification. This is not for ulcer, this is for wound. You must learn it because this is often asked in the exams. So we have stages and grades. Stage A, when there is no infection and there is no ischemia. But patient can have a grade 0, 1, 2, 3 level of wound at that time. Okay. So grade 0 is when there is pre or post ulcerative lesion, which is completely epithelialized. So obviously there is no infection, no ischemia, and there is no ulcer. Whereas in grade 1, there is superficial wound not involving tendon, capsule, or bone. In grade 2, there is wound which is penetrating to tendon capsule. And in grade 3, there is a wound which is penetrating down to bone or joint. So these are the gradings, okay? When there is a stage B, there is in presence of infection along these wounds. And when in stage C, there is a presence of ischemia along these wounds, these grades of wounds. And in stage D, there is infection as well as ischemia along the grades of these wounds. Now, I hope you're not confused with the grading and staging, because you can get a very healthy wound, which is a grade 3 wound, but at stage A. Are you getting it? Like if you visit our diabetic clinic where our Sadat Bhai works, okay, there you will find that patients are visiting him for weeks and months. Their wound can be bone deep, like grade 3, but it is at stage A. That means the wound is not infected. There is no ischemia. It's a healthy wound, okay, but it is quite deep. It has healed up. I hope you are clear with this. Now, moving on to the ulcer classification, which is also very frequently and very much asked in the exams. That is the Maggot-Wagner's ulcer classification. Class 0 is intact skin and there is no ulcer. 1 is when there is superficial full thickness ulcer. 2 is when there is deep ulcer penetrating down to the dermis, fascia, muscle, or tendon. 3, when there is deep ulcer with abscess or osteomyelitis, that means the bone is now involved. So the dividing class is class 3, right? When there is bone involvement. After that, if there is a gangrene or toe of part of the foot, then that is class 4. And if the entire foot is involved, then that is class 5. So this is very important. You must learn it. It is often asked in the exams. Now let's begin some exercising or brainstorming. Which class of ulcer would it be? I mean, you can see at least it is bone or muscle, muscle or tendon deep, right? So according to this classification, it is class 2, I suppose, 2 or 3. Okay, we have to see whether it is 2 or 3 by probing and see that whether it is deep down to the bone. And so if there is osteomyelitis or abscess formation. Now, what class of ulcer would you label this foot? Class 4, okay, because you can see clear-cut gangrene over here, okay? So treatment would be a patient education, which involves so many things before anything else. So patient education include ambulation, proper shoe wear, skin and nail care, avoiding injury like hot water, foreign bodies, Then proceeding on to the level of treatments, including podiatry, proper foot care setup, offloading devices, and then treatment of ulcers. A multidisciplinary team approach is very much required in such cases. Consultant diabetologist, diabetes educator, dietitian, foot care assistant, physiotherapist, all have their role to play. Then there are orthopedic surgeons, vascular surgeon, interventional radiologist, interventional even cardiologist, orthotist, and nurses. Okay. And now a little bit about what is podiatry. This is a medical profession which is devoted to the study and medical treatment of disorders of the foot, ankle, and lower extremity. Uh, Basic purpose is to debride the wound to bleed for healthy wound healing. Use of normal saline, iodine, use of solution, specialized dressings, and there is no topical antibiotic. So you see, nothing related to the allopathic medication, but it is a profession of its own. And you know, internationally, people do a whole graduation degree, and they are called podiatrists. They have a 4-year podiatry program to become professional podiatrist, which is then they which is how they become the part of these multidisciplinary teams of diabetic foot and diabetes. These are the various offloading methods which I'm showing you. This is the foot ulcer which is present on the plantar surface, and this is how they have offloaded it. The pressure goes on to the rest of the foot surface surrounding the ulcer, and the main area of the foot ulcer is offloaded. Offloading means you are allowing that wounded area to heal through proper blood flow. This is another example of offloading. These pictures I have taken from, Bakai, Bakai Institute. These patients are Bakai patients. And because, Diabetic Foot Center is quite well developed over there. This is other offloading devices, baller iron. Okay, you can see here there is a wound down on the plantar surface towards the heel of the heel part here. And this is how offloading device is used. This is called Scotch cast, through which they have offloaded plantar surface wound, probably near the metatarsal heads. This is called modified rocker bottom device. Okay. These are the specialized sandals which are prepared for offloading. Now coming to the foot care based on risk factors. If the person has a low risk of developing a diabetic foot, annual comprehensive foot examination is fair enough with questionnaire completed by the patient and examination performed by the specialist. Self-management and footwear education, which include brief counseling and even written handout. We don't really pay much attention to this part, right? We should do that with all patients. This is how we can prevent them from getting onto the high risk categories. So patients who have high risk features, they should have annual comprehensive foot examination, inspect feet at every office visit, podiatry referrals and cares as needed, intensive patient education, detect, manage barriers to foot care, and then therapeutic footwears as needed. High-risk patient also need nursing tasks to be achieved, like nurses should place the high-risk feet stickers on each chart, remove patient shoes, socks, determine if patient can see the soles of feet, stock 10-gram monofilament in each room, consider training to perform monofilament examination and provide patient education. This is actually, diabetic foot nurse's task. Not everything has to be performed by the physician or diabetologist. You need a teamwork, right? The patient comes, patient can visit the nurse, And the nurse should be a diabetic foot nurse. He or she can do so many things. These are not very high rocket science things which need a very advanced level training and so on. uh, if you train these nurses for such examinations and such work, they can perform their task very well. Then come the patient education. Reinforce frequently, low retention, because these points can be easily missed. Low retention, right? Patient demonstrates self-care knowledge. Make sure patient know everything. It is not enough to tell and inform the patient that these are the care points you have to understand. You have to recheck that if the patient has understood or not. This is a very important feature of counseling. I hope you all know, especially the ones who are doing FCPS now, that it's not enough that you inform. You have to make sure that the patient understand what you have informed. And then evidence may be there will be reduced foot ulceration, reduced amputation rate. This is how you get a feedback of your care and your education and your treatment. Then involving the podiatry care, provide nail and skin care, assess footwear needs, visit frequency, not evidence-based, and equinus management. So how frequently the patient has to visit is not scientifically proven yet, but you can judge yourself and make your own standard protocols. Basic foot care concept, daily foot inspection may require mirror, magnification, or caregiver. Patient able to recognize and report persistent arrhythmia, enlarging callus, pre-ulcer callus with hemorrhage, all those features which I have described earlier. Then basic foot care concepts should be provided to the patient. Commitment to self-care, wash, dry daily, lubricate daily, not between the toes. Make sure that between the toes there is dry area, there is no wet area, because wet area can hibernate fungal, can be the nidus for fungal infection. Debride any callus or corn, especially in the low risk patients, and no self-cutting of nails if there is neuropathy, peripheral artery disease, and poor vision. Then protective behavior should be advised to the patient to avoid temperature extremes, and no walking on barefoot, stocking footed. Like we should explain to the patient that wear proper shoes and don't go barefoot outside. Appropriate exercise for insensate foot. Inspect shoes for foreign objects and optimal footwear at all times. These are very important basic points which we hardly pay attention to. But if really, if you talk about these small points with your patient, and they hardly take 1 minute to talk about, you should learn, make your own 2-3 sentences as a practice, that I have to tell these points to my patient at every visit. Then that is enough. You don't have to deal with high uh, clinical consultation behavior over there, and your patient can take so many good things back home that my doctor has explained me so well. So basic footwear education also include to avoid pointed toes. Pointed toes, like shoes should not have pointed fronts. Okay, they should be broad. So avoid pointed toes and broad round toes. This is about footwear that we are talking about. Slip-ons should be avoided, and they should be adjustable. Laces, buckles, Velcro for proper support and comfort. Open toes should be avoided to avoid any injury. High heels should be avoided. Plastic footwear should be avoided. Black color should be avoided, and too small footwear should be avoided. Rather, there should be athletic shoes, walking shoes, more comfortable type, leather texture or canvas. White or light color is better than black color. And half between long toes and end of shoes. There should be a half-inch space, okay? There should be a space when the footwear should be the type where if the patient has put the foot inside the shoe, there should be at least a half-inch space or gap between the toes and the shoe end. I hope you're getting this point, because this is a very subtle point and we don't pay attention to this, right? Now coming to the treatment of ulcers. So in case of Wegener-Megget 0 to 2 class, that is the one which is not involving the, which is deep or muscle or tendon deep, but not causing abscess or osteomyelitis. So total contact cast, offloading devices, distribute pressure, and allow patient to continue ambulation. Principle of application, like changing, padding, removal, and antibiotics if is superficially infected. This is an example of total contact cast where the whole foot has been, offloaded. Coming to the treatment of 0 to 2 Wegener further, if surgical treatment is required, if deformity is present, that should be corrected. Otherwise, it will lead to reulceration. Correct any deformity, exhaustectomy, or regular debridement if required. Coming to the Wegener class 3, excision of the infected bone, because here we are talking about osteomyelitis, right? Wound is then allowed to granulate. Grafting with skin or bone is not generally very effective. Just remove the dead tissue and infected tissue. Coming to the Wegener class 4 to 5, here you may go on to amputation of the foot. An indication can be uncontrollable infection or sepsis, inability to obtain or dry foot that can tolerate weight bearing, non-ambulatory patient, patient cannot move because of the foot ulcer, and decision is also not always very straightforward. You have to have a multidisciplinary approach and decide the level. After the ulcer has healed, orthopedic shoes with accommodative custom soles should be provided. Education to prevent recurrence. This is very important. And here the role of orthotics comes. Just as I explained what is podiatry, similarly, there is another field which is called orthotics. Now, these orthotists, they also have an education degree internationally, a 4-year or 3-year degree program, after which they are called orthotists. They come to see the diabetic foot patient to assess the type of foot they have and what type of shoe should be made for them. You can see these are very specialized type of shoes, and they are designed by these orthotics. So in conclusion, multidisciplinary approach is very much needed, which we know because diabetic foot is now going to be an increasing problem with the passage of time. There is a high morbidity and high cost associated. Solution is probably in prevention, which we don't pay much attention to, unfortunately. And most feet can be spared at least for a while. So thank you very much for your kind attention, and I can answer any question if you have.